ASH 2015 coverage continues. I'm Thomas Baldrick here in Orlando, Florida. We're happy to have with us Dr. Lori Ann Linkins. She is from McMaster University in Hamilton, Ontario. Thanks for coming by today.
Thank you so much for inviting me.
So we had Dr. White's here with us talking about similar things. We'll turn the baton to you. Let's talk about Rivaroxaban for treatment of suspected or confirmed heparin-induced thrombocytopenia study. What exactly did you do here and why?
Okay, so as you may have already discussed with other investigators, heparin-induced thrombocytopenia is a very serious adverse reaction to heparin, and patients are suspected to have it if they develop thrombocytopenia or thrombosis. And our study was actually looking at using a different agent for treating HIT than is standardly used. So we enrolled patients who had suspected HIT. We gave them Rivaroxaban until either HIT was ruled out by the local assay, or if HIT was confirmed, we continued until 30 days. Then we had a look at the incidence of recurrent VTE, or recurrent venous thromboembolism, or new thromboembolism, and also arterial thromboembolism in these patients at the 30-day mark. So we know that HIT is a very aggressive thrombotic condition, and if you don't give an appropriate alternative anticoagulant, up to as high as 35 to 50% of these patients will develop a clot. We had a total of 22 patients. The study had to be shut down early because, unfortunately, of poor enrollment, but we did enroll the expected number of patients for SRA positive HIT. HIT is suspected in a large number of patients, but only about 6% of them will actually be proven to have it on testing with laboratory assays like the SRA. So in our study of 22 patients, we had 12 patients who had HIT confirmed by the SRA, and all except for one of them got through on Rivaroxaban without having another thromboembolic event. The one patient who did have a thromboembolic event was somebody who had an apheresis catheter that was in situ and actually remained on study drug, but because we couldn't rule out the possibility that their clot had gotten worse on it, we have to count that as an event. So our event rate was 4.5%. Compare that with the event rate in the Rivaroxaban historical control trials, which is about 11%. Our results are in keeping with what we've seen in the literature, keeping in mind that our confidence intervals are quite wide because the sample size was quite small. So we're actually very excited by these results because Rivaroxaban is a very easy drug to use. Drugs like Rivaroxaban are not. So this is a drug that we can give orally. We don't have to monitor it from a laboratory coagulation perspective. And it's also relatively inexpensive, costing dollars a day as opposed to thousands of dollars a day as some of the alternatives cost.
Which is a real-world factor for patients.
It's a huge real-world factor, not only for patients but also for hospitals. If you have a patient who has HIT and you have to put them on something like Rivaroxaban, they're hooked up to an IV, they're going to be in your hospital bed for several days. So they're not only incurring the cost of the drug itself, but the cost of being in a hospital bed. If you can put them on Rivaroxaban and they've reached a safe level with their platelet count, you can send them home. So the costs drop.
Let me ask you, as a doctor, as an investigator, how do you weigh the importance of the financial aspects of things like this?
Well, the reality is I have to consider that. I mean, in an ideal world, we give patients whatever they need in order to get them well. In reality, we have a lot of patients who don't have funding for medications. I'm lucky in Canada that we have more coverage for a larger proportion of our patients. But I can tell them that they should take a drug. If they can't afford it, they're not going to take it, even if they tell me to my face that, oh yes, they'll go fill the prescription for it. So I think it's an extremely important part. And so drugs that are much lower cost for them are much more likely to be taken, which means we're going to have better outcomes.
So you're excited about the findings you have so far. Where do you go next?
Well, I'd love to say that I'd do a larger trial, but to be honest with you, I'm not too sure what's going to happen at this point. We learned the hard way that HIT as an orphan condition is incredibly difficult to study. And I think that we would have had to have maybe triple the number of centers that we had in order to achieve what we originally had set out to, which is to enroll over 200 patients. And from a cost perspective, only this time we're talking from a research cost perspective, right, it's more or less prohibitive. So I think we're probably going to be seeing more prospective cohorts come out, maybe some case series, very similar situation to fondaparinux, which is used off-label in many, many countries, but will never be tested in an RCT because, again, it's too expensive to actually do the study properly. So I'm hoping we'll accumulate more data over time.
So leaving things where they are now, what do you think the findings that you have, how do they impact physicians?
Well, I think that physicians have to use some discretion and they have to be aware of the limitations of what we did, but I'm actually very excited by it. And I've actually started using it in my clinical practice. One of the drugs I mentioned already, fondaparinux, off-label, including in the States, is used more frequently than any of the other drugs at this point in time. I'm just as comfortable with using Rivaroxaban off-label. We had in our 12 HIT-positive patients, we had at least 6 of them that were very strongly positive for HIT, and they had very high D-dimer levels, very low fibrinogen levels, very aggressive HIT patients, and they did very well. So I consider that to be enough for me to be comfortable with using it in specific circumstances, but certainly I'm not saying that, that it should be used indiscriminately. You have to use careful thought.
Very good. Thank you, Dr. Linkins. We appreciate it.
Thank you very much.
Thanks for coming by.
Thank you.
Okay.